right, well, welcome everybody to our second year of Developmental Disability Round. Second Tuesday of every month, Sarah will send an email around to everybody with specific dates. So this month, right, I was just checking to see if you were on the wall. Good for you. So that's, I think you get B- for that one, Sarah. That was good otherwise. So this month we are fortunate to have Dr. McLean talk about developmental coordination disorder. And I must say that Jennifer sort of stepped into the breach. We had somebody else who had said they would talk, and 2 or 3 weeks ago, of course, they had left Western and were no longer able to do the presentation. So Dr. McLean kindly stepped into the breach and has saved us all. So Dr. McLean.
They got out of it because they left Western. I didn't know that part of it.
The only way you can get out of it.
Okay, all right. Okay. All right. So I thought the royal we thought we'd do something a little bit different. And so actually this is based on work I've done over the years and looking at seeing children who have motor coordination difficulties, either fine motor or gross motor, that don't have hard neurological findings or abnormal MRIs. And there's a lot of these kids and they're under-recognized. But how that associates with other diagnoses, I think, becomes very important. So the title of the RIP talk is Clumsy Child, the Interplay of Child Psychiatry and Developmental Pediatrics. And we actually do work well together. We just want to say that out loud. Always. Okay, so does anybody know where this is taken from? Does it look at all familiar? It's fall. That's the only thing I'll say. It's where?
Here.
It's London, yes. Though I wasn't.
Yeah.
The trick question wasn't where.
There's the art gallery.
Oh.
Warncliffe and right.
So then would it be Riverside?
Yeah, Riverside.
Forks of the Thames? Nope.
Okay, so what do we have? Riverside. Anybody? Fork of the Thames. Anybody?
There's a little jet, the Vietnamese restaurant.
You can see the Vietnamese restaurant.
Yeah.
Oh boy, she's good. Okay, so London.
I can see the restaurant.
Okay, just to have a good laugh, the picture that used to be here was actually a picture of Halifax, because this talk started when I was in Halifax.
Oh.
So we had to change it. Okay, so what we're going to do is talk a little bit about the characteristic presentation of children with DCD in healthcare and education, both settings. We're going to review the current evidence with regard to what the possible etiologies are, how you identify, how you diagnose, and how do you manage in a practical way. A little bit about resources to support not only the children, their families and teachers, and current research into the coexistence of other disorders with DCD. So I'm just going to say I've had a little bit of a personal journey. I've published a little bit along the way, so I'll just skip by that. Don't stare at that. Okay, all right. So a lot of people have been involved in this research over time, and you can see there's a lot of people that I've been affiliated with over time, so all legitimate kind of people. We'll just say it that way. Okay, all right. So there's this little guy. He looks like some of the guys we see. Okay, so what do the parents notice at home? Well, he's got trouble with zippers, buttons, snaps, and shoelaces. He may have trouble buttering his bread, cutting his meat, and even open those silly juice boxes. He has difficulties participating in physical activities with other children, and he may have trouble coloring, cutting, pasting, or painting. We call those the C's and the P's. So, what does the teacher say? Teacher says, well, he tells interesting and very complex stories. It's very verbal, and his reading seems okay, but he can't copy from that blackboard, or now the whiteboard, so I should put that in there now. And his printing's terrible. And when he does use his pencil, it's like his death grip, right? So that's what she sees. So he seems rather frustrated. So Eric may have developmental coordination disorder. So we're going to talk a little bit about that. So somebody famous, Daniel Radcliffe, Harry Potter, in case people don't remember, who's gone on to other things. Anyways, he is a little guy who was diagnosed with dyspraxia in England, because that's one of the terms that used to be used for it. And you'll still see dyspraxia coming up in the research. And he says because of that, that's how he got into the issue about acting like I was a typical person. And he got into acting as a way to help as one of his strengths, but also to help with one of his difficulties in being a little bit clumsy, uncoordinated, little bit difficult as with fine motor issues. You got enacting as a way to deal with issues. Okay? And he says things like, quote, why or why has not Velcro not taken off? Velcro should be on everything, including the top of your jeans. So I've got to put in context here. Okay, coordination difficulties in children. Over the years, have had a number of different names. All right, we had the Clumsy Child, which we've had the motor coordination problem kid. We used to call the pencil grip kids. So for the occupational therapists, we used to call those the pencil grip kids. Developmental dyspraxia, that's more of a East European kind of diagnosis. Sensory integrative dysfunction was up there. How about the mineral brain dysfunction? We used to say that about kids. Oh. All right. And then there was DAMP that was around for quite a bit for a while. Disorders of attention, motor, and perception. Okay, so big consensus of people. And guess where they came to? London, Ontario. There was a big consensus back in the 80s, early 90s, and together with Mervyn Fox, who was one of the founders of Developmental Pediatrics in Canada, all across the world, we now call it coordination disorder. So another thing he'd say at London's famous about, just so you know. I heard Jeff talking about famous people. I don't talk about Teresa, I'm adding one of mine. All right? Okay, so DCD. So big question is it a real disorder? Well, a lot of physicians, a lot of teachers, preschool teachers see the kids and said, leave him alone, he'll just grow out of it. There won't be any repercussions, he's just a little clumsy. Well, we know that's not true. Normal variants, well, we're all not athletes, so what's the problem? Well, except these kids have more trouble with that. Distinct diagnosis, it is a disorder. It has severity symptoms and has impact on major life activities. So did it make it to anything called like a DSM-4 or DSM-5? Yes. In fact, it was in DSM-4 and is being reworded in DSM-5 to make a couple of points. First of all, it's motor. So you have to have motor skills that are substantially below those expected given the individual's chronological age, and also their opportunities for motor learning, skill learning. So if a child's never been exposed to a bicycle and they can't ride it first time, doesn't mean they have DCD. You have to have had those skills, all right, and that opportunity. The motor skills deficit significantly persistently interfere with your activities of daily living, impact on school productivity, or as an older child, pre-vocational, vocational activities, leisure and or play. It's got to impact on those things that are part of participation for a child's life. The onset of symptoms is in the early developmental period, and the motor skill deficits are not better explained by intellectual disability. For example, a child with Down syndrome will be hypotonic. They will be delayed in gross motor development. But unless the degree of motor deficit is lower, significantly lower than where they are for their developmental level, one would not diagnose that. And of course, children who are visually impaired, it makes motor coordination difficult. Or a neurological condition, for example, cerebral palsy, that can affect motor movement. Okay? So, we, over time, have come to the 5 C's of developmental coordination disorder. And that's an easier way to remember what the impact of this is. So, C, common. 2, clumsy children. There's got to be a motor problem first. It is a chronic health condition. It has comorbid issues, and it has consequences. So, the 5 C's. All right, well, common. Well, how common are we talking about? This is when everybody looks at me and goes, what? Yeah, about 5 to 6% of school-age children. So we're talking about 1 or 2 kids in every classroom. So obviously they're not diagnosed, so what's going on? What, they just act up. Isn't that all they do? Class clown or frustrated? No, they actually have problems. So the gender difference, again, males. Sorry about males. It's always males. And you can see, but girls may often be under-identified because they're the ones acting out because they're having motor coordination disorder. And we know there's an interaction between the gender and the behavior complex with males having more difficulties. Okay, so let's talk about the clumsy part. Okay, here it comes. There it is. They're clumsy, but they can have a what we call heterogeneous profiles. So they're often low muscle tone kind of kids. So they either contract their muscles to keep themselves together when they're doing activity. You'll see the run. They don't bend their hips and their knees, and they aren't smooth like that. They're disorganized. They have difficulties with co-contraction, joint stabilization. They really rely on their vision with which to help where they're doing motorically. Oftentimes, they remain at the new learning stage. So it takes them longer and longer with practice and practice to get there. And then if you learn one particular skill, they have trouble transferring that to another skill activity. So for example, they can learn how to play soccer, but it's going to take some time. You have to break the skills down, and they have to learn how I'm going to go through, where do I place the ball, how do I kick the ball, with what degree of force, and how do I get the direction. It's going to take time for them to sort out. Whereas other kids, you give them the ball, and we know this when we see young kids playing little kids soccer, they stand up there a couple times, next thing you know, they've got it, right? These are the kids that aren't going to do that, but they will learn over time. They also have safety issues because of it. Balance difficulties, they tend to fall or trip more easily. They have more injuries, and because of that, the safety issues too, they're trying to do activities, but don't realize where their body is in space, and can run into more trouble. So, etiology mechanisms, a lot being looked at in terms of this, a lot of new stuff's coming up. So I'm going to give this, and I'm going to give the new stuff. So brain CT scans and MRIs are negative. So what does that mean? That means the structure of the brain looks normal. You can't see anything structurally, but it doesn't tell you anything about its function. We talk about atypical brain development and sequence of development. We all know that there's sequences of motor development, and you have to have head control before you can have trunk control, before you can roll over, before you can crawl, and all those things. Well, these kids have a dyssequency of how they do things. They have difficulties with that optimization. So like we talked about, learning a skill, but not automatically learning by just watching. They have to break it down and practice each step. There could be a cerebellar issue. They could have kinesthetic, proprioceptive difficulties. And people who work in the sensory integration field will often talk about those issues. And visual spatial problems. Visual feedback is managed differently and processed more slowly. These are all the thoughts we had. But so now exciting time. Please let it be there. Hold on. Hold that thought. I'll be there in a minute. I put it in a different order last night. Okay, it's chronic. I just want to make sure that. So it persists into adolescence and adult. They don't just grow out of this. And it may not be all fine motor or gross motor. It could be a combination. And they're still affected during activities of daily living. And you will see people who are slower at the dressing area, slower at the buttons. Still, as adults, have trouble with those little buttons of the cuffs they have on them. Still have trouble with that kind of thing. They're still having difficulties with the fine motor. But nowadays, they've been able to translate that into typing and doing those activities. So they've compensated for their issues. Okay, so comorbid. Let's talk about this. You got DCD is comorbid with ADHD, comorbid with learning disorders, disabilities. There you see lovely Venn diagrams, okay? So when we see kids with ADHD, not only do we do what we normally do and looking to see what else could be contributing to those kind of symptomatology, we should also be looking at the motor component here. Because we look at the motor component and we find that these kids also have motor coordination difficulties. If you help with that, that can often improve some of the attention issues, okay? Or at least you're not missing out that you're working with both together, right? Since the DSM-5, this used to be a controversy, but now since the DSM-5, children with ASD can have co-occurring DCD diagnosis. And a lot of children with ASD actually have motor difficulties. And we often don't recognize those. Okay, so there's been a lot of association between DCD and other developmental traits. There's been a lot of studies gone on over time. The Avon longitudinal study, parents and children, with the DCD on that particular test being probably less than 15% of your ability to function in the motor areas. At age 7, with the functional impairment, they had in ADLs and handwriting. These children had no neurological difficulties. Their IQs were not less than 70. And the children with DC had increased risk of difficulties in attention, social skills, reading, and spelling. So the motor was never on its own. The social, I'd look at the whole child in terms of what was going on. In the Swedish study, they were following up the 7-year-olds of children with ADHD. They found 50% of the children with ADHD, when they looked for the motor issues, they were there. That's pretty high. Those with ADHD and DSD also had increased risk of autistic symptoms. So how many do we see where we think about that? It actually come in the door the other way. Are they ASD? And we need to look back at the other part. Those with the ADHD only with no DCD had lower risk of autistic symptoms, but a higher risk of ODD and conduct disorders. So important to distinguish those kids who have ADHD with other comorbidities, ADHD with DCD.
You think that 50% is correct?
I think it's probably in the right ballpark for this, yeah, because we're noticing that over time with more studies. So again, but there's different degrees of developmental coordination disorder, right? Whether it affects just fine motor or gross motor or a combination of the two, right? Okay, so there's specific connection between these. And the mediation is by DCD is what we're thinking right now. That's the work hypothesis. So mood and anxiety symptoms. This is an Ontario school-based study, grades 4 to 8. It's now published, by the way. They had a little trouble, and now it's published in 2013. So, you know, those with coordination problems had increased symptoms of depression and anxiety compared with typically developing children. Those with ADHD, again, 50% had DCD or were more likely to be anxious and depressed. So that's later where it gets financed in Ontario. Take-home message for any of these kids: don't ignore the motor part. And we often don't put that as part of what we assess. Okay. What about the extremely preterm, extremely low birth weight infants? We're seeing more and more of those kids surviving and look like they're functionally doing well in the preschool setting. Then you get into school and they're running into more difficulties with learning and attention. We know that. So this is a geographic cohort in Australia. Subjects were born in the 1990s. So, I mean, not bad neonatal care then. And it says 8 years. The prevalence of DC was 16% in the extremely preterm or extremely low birth weight group, and about 5% in the comparison group. Academic outcomes were poor for those with DCD than those without. So if they had the motor part, they had poor outcomes in academics. And the conclusion was that these children had higher rates of DCD, and those with DCD had increased academic difficulties. We now know that when Swicker now in 2013 has just come up, that the perinatal neonatal predictors include, again, male sex, low birth weight, and postnatal steroid exposure, which makes sense when you think about it, because those are the kids who had higher risk neonatal complications that end up getting postnatal steroids, right? So brain activation. Now, this is the exciting part that's going on. And some of us had the opportunity to see Jill Swicker, who's an occupational therapist who runs a research and clinical DCD clinic out of BC, was presenting recently on taking that from the MRIs and CT scans showing normal structure to watch the functional differences that occur with children with DCD. She's got beautiful pictures. If you hang on, I'll give you a site where she's just done all that which one can look at. So purposely determined if patterns of brain activity differed between children with or without DC while performing a motor task. And there were different motor tasks that kids were to do. So she used functional MRIs in children. Her numbers are greater now, and I didn't have time to publish the very latest, but this is up to 2010, 2011. And they definitely did a fine motor, a trail tracing. So there was a maze thing they had to do, and they had to do this while they were at the functional MRI. Conclusion: with the DCD children activated different regions from typically developing children. The DC children activated those areas responsible for visual spatial processing were activated, while the typical developing group activated those areas with spatial processing, motor control, learning, and error processing. So when you think about the differences, when the DCD children were doing it, they were using visual spatial more, whereas the typical developing children actually were using that thing about spatial and visual, but the motor control areas, they were looking at the learning and error processing. So if I went that way and it wasn't working well, I knew how to correct it and self-correct. They were doing more, taking more of those parts of the brain with which to help them. So what this is getting to is exciting because it's making the point that the function of the brain, the structures may be fine, but the function of the brain and how it's used with children is actually different. So this is the first step in that. She's doing a lot of neuroimaging studies, and this is where the beautiful, I didn't bring all those, but she's got some beautiful things to show. They should activate more in different brain regions than typically developing children when they're performing motor tasks. That underactive brain regions are underactive, the ones associated with motor learning in the children with developmental coordination disorder. And there's altered development in the way of sensory and motor pathways. So this is her main focus of her work right now. Mm-hmm. Yes, please.
All these kids with developmental coordination disorder, they had other comorbid conditions?
No, they tried to, that's why you saw the numbers. They were trying to get them pure.
Okay, so they didn't have, okay.
Yes, that was the point. Tried to do them pure without having the other ADHD and other things associated with it. And of course, that's hard.
Yep. Well, said,
Right. But they do, because they run a research consortium, they're able to get those kids and test them for ADHD, test them for other things. So they tried to get a pure group here. Okay. So consequences, well, we know the other things. Because kids who have fine motor issues or gross motor issues will often have school refusal, avoid a task, okay? And of course, you get behavioral and academic issues with that, both in terms of learning the academics, but also feelings about your self-esteem, your social ability, and often also, because of that, but then once you get bullied. So when we see the bullied kids, it's important for us to be looking at, as we do, underlying reasons. But one of the underlying reasons may have things to do with motor coordination. Okay. Mental health consequences. Well, now we do know there's an increase for the developmental health problems of these children. A lot of them present with significant anxiety, depression. So again, putting the plea up for that. And of course, that whole affective cycling of how things occur. All right. These are the same kids that often end up being couch potatoes and watching video games because they're good at that, but not good at the gross motor activities. So what ends up happening? They start gaining weight, start feeling badly about themselves, and the whole cycle goes around. So the reduced participation in physical activities. Because of that, they often have decreased strength over time, low endurance to do an activity, deteriorating physical fitness. So as an adult, this becomes very important as well. Increased risk for obesity, and of course with that are all the cardiovascular complications that can go with that. So it has long-term consequences. So I wanted to make the point out of something called CanChild. CanChild is Canadian. It's out of McMaster. It is a consortium of a number of members who've worked in the rehab field for years, who work on evidence-based medicine and research. The neat part about this is all free. You go to the CanChild website, and all this stuff is there. It gives you everything about how to do an interview, what kind of tool can you use to assess in your office, what kind of tools can you use to have parents in schools report back on what kind of motor coordination issues they have. They have what's called match strategies, which we're going to go to in a second. And they also have, for each grade range, what we call match strategies. So I'm going to talk about that. So there's a development coordination questionnaire. And this is what it looks like, so I'm going to put it around. It's parent completed, takes 10 to 15 minutes. There's 15 items, and it's a Likert scale on it. It talks about child's motor performance relative to that of same age peers. It groups into 3 categories from it. You have control during your movement, motor control during movement, so the running, the hopping, the jumping, kicking balls, during fine motor and handwriting tasks, and overall general coordination. So it gives you a good idea, if you give that to a parent at a preschool or school, what's the child's functional difficulties with motor coordination. So you need active involvement of the child when you're talking about management. You need to prioritize what's functionally difficult for that child. Teach the special skills they need, so breaking down the activity to make it more generalized. And we call it a co-op approach. You have a goal, you need a plan, you need to check how you're doing it, and then do it. Right? So with that co-op approach, we can teach things like bicycle riding. Don't just somebody holding at the back of your seat and running behind you. These kids are going to learn how to ride the bike that way. So you break down the skill and you teach it. So match strategy, first of all, you modify the task, you alter your expectations, you teach the strategy, change the environment, and you help by understanding. On the CanChild website, for each grade range, they talk about what the functional skills a child needs to have, gross motor and fine motor. And then it breaks it down. So it says, if your child has trouble with pasting, gluing, painting, these are the strategies you can do. If your child is having trouble with printing, let's break that down. Use the magnetic letters initially when you're JK and SK, right, to do that. Use the foam letters to get it smaller. Use the tracing letters, different ways to do it instead of just having them do this. Right? Having them practice R and R and R again is not going to solve the problem. You need to break it down so that they can say things like, I can feel it and I can see it. So for example, to make an R, you'd have the child talk himself while he's looking at it, and once he's done, he knows what the letter looks like and everything, he's going to do make a line like this, and that's going to be his hold, or whatever, stand up. Then you're going to do a bubble, so he knows it's a bubble, and then you're going to kick it away. So what he does to himself is just talks him through it, as well as seeing it visually, and he learns it that way. He doesn't just learn like draw an R. That's not going to work. Okay. So future treatment modalities. So lots looked into whether we can, with the scarcity of therapists, right? We act as consultants, right? So consultants are very helpful because they're like coaches. But in our environment, a coach cannot be there all the time. So what we've done is through the CanChild website, we put together resources together so we can teach the parent, teach the child, teach the school, and teach the coach how to break down the activities. So you don't need to have a therapist right with you all the time, all right? Now, then we thought of other things. Is there any tele-intervention we can do? Are there any other things we can do as WeFit? Everybody know what WeFit is? Okay, WeFit. So we've been using that as a training protocol for children with DCD. So in other words, if you want to teach jumping or jumping jacks, use WeFit because you can break down the skill little by little so you get each part of the skill and then gradually put them together. And then he can go outside, he can do his jumping jacks with the other kids. Right? And we've done, they've been different in, for the Wii motor learning examination, virtual reality as well, and other areas being looked at. So these are all exciting things that are being looked at as ways to help these children. And it's important because if they can learn the skill within their environment, then they can extrapolate that out to be with other kids because their self-esteem is pretty low about all this. So you want to keep that down. Okay, so this is the exciting part now. March of 2017, the Canadian Association of Pediatric Health Centers, I had a consortium together expanding on the role of CanChild, but said let's take it from the research, make it clinical. All right, what can we show? So Jill Swicker is one of the people on it, and it's just March 2017. It's on YouTube, and I was able to get it very easily last night. And she goes through what I talked about, the resources, how to help children and families, and making the other point though, these are the same kids that have mood disorders, anxiety, that may present as ASD, may present as ADHD. Think about the motor component of it and work together with that. So that's the basis of my talk, and I wanted to open it up for discussion. And see you later. This is what the parents get after you make a diagnosis. And there's more information. One of the ones I was involved with, and just toot my home for 2 seconds because I don't often talk about myself, was why every office needs a tennis ball. So in a community practice setting, what do you use a tennis ball for? Child to catch, child can bounce it, bounce to get the ball. You can take a look at how a child quickly learns or not learns. You can learn how they break down a skill. You can learn, are they able to visually do it, copy you, and do it with the same force to be able to bounce the ball. So there's things you can do right away in an office setting to be able to diagnose this. So it's one thing I've done over my lifetime. All right, and then we have the last one. Does anybody know what this bird is? Hey, a plant in the audience. Tell everybody what it is. Yeah, or the blue-footed booby or BB, depending where you're from. Okay, so the interesting thing about the blue-footed booby bird was he takes off and he flies and he soars and he looks wonderful, he does well. But he's got a little problem. When he comes to land, he can't figure out the motor coordination. So when he comes to land, he's coming to land, he doesn't quite know how to slow down properly, spread it out so that he's going on plateau surface, so he tends to drop and falls over. He's got a little problem with motor coordination. He's the mascot for this. So he's got great things he does well, flying and flying. He's got trouble with motor coordination for landing. So there we go. Okay, I'm done. It's open for discussion. I hope I made it a bit fun and so that I will have the interaction. Yes?
At what point do you actually say, and I'm interested in the objective sort of criteria for diagnosis?
Yes, because I'll talk about that.
Move from the child being a clumsy kid to having a developmental coordination disorder.
Yes.
For example, I'm a clumsy golfer versus, I shouldn't even mention his name, Tiger Woods anymore, or a routine hockey player versus a Wayne Gretzky. So at one point,
Yes.
you would say to another, this is a clumsy kid, but then the world is not made up of high coordination.
And I can easily answer that.
Versus you have your child has developmental coordination disorder, and it's really going to have major problems.
Okay, all right. I do see some OTs in the room. Good, so I'm going to say this. So over time, a lot of work's been done on what tools can be used to assess motor coordination. And there's a lot of tools that have been used by OT and PhD over time, including, which I was going to say, Rob, I'm just going to say the Brunics, or let's see. Okay, all right, good test, okay, but it's not specific for motor coordination. The one that's mostly specific for motor coordination is the movement assessment battery for children. And the movement assessment battery for children can be done by a physiotherapist or occupation. This is where you need your physiotherapist or occupation to do the assessment part with you. And that helps because we know at what level, what cutoffs are we considering significantly below where they should be for their developmental level for that skill. And it helps do the cutoffs for that. So you can actually get that assessment, and then you look at their functional ability as well and pull it all together. So they can learn the skill, but you have to know that part about, do they need it broken down? Does it take them longer to learn that skill as well, whatever it is? And that's how you make the decision about that. The good thing about the interventions, A, they're not harmful. B, they have people think about how to break down an activity to teach a skill to help the child generalize. So the tool we've come up with is movement assessment battery for children, which I didn't go in because I'm not an OT and PT, but I will say that.
So along with that, Jennifer, then, the instrument passed around was a parent completion.
Yes,
How
it's
well,
nice to gather the information. It's a tool.
how well does that coordinate with OT or PT assessment?
It actually does quite well. And in fact, it has very good properties in terms of iterated reliability and predictive value. Yes, I know. Hi. I remember you. Yeah, hello.
I encountered this in my practice. One of my questions, when I think about auto processing disorder,
Mhm.
the other thing I used to say in these cases is that
Yes.
this child, 6-year-old, has that's the, so now I'd like to refer those. What's the procedure?
Okay. So the key part, yeah, the key part of these kids, you need to do a good physical examination, obviously. And you're looking for any, neurological, especially focal findings. And if you don't have that, and the tone is lowish tone, they often have mildly increased joint laxity, and that's about it. Nothing else, okay? And then at that point, they don't need to see a neurologist, number one. In fact, that'll be a waste of time. He's going to say he's got a fairly normal neurological examination, right? And you've waited 8 months for that. So the best part at that point is to do something like gathering information from the home and school about what is his functional difficulties in the motor. That's why I gave you something you can pass out. The second thing is asking for an OT or PT to do a motor coordination assessment. Yes, and it's a one-time thing. So often you can get that. The problem is when you're asking for OT or PT at school level, they just don't have the resources to do that. But a one-time thing with a specific test in mind, and then there's different ways of getting that done.
What are those different ways?
No, I just meant that it said one assessment, rather you're not asking for ongoing.
Will
Right.
school people do that?
They have, yes. Yes. Especially if I say to them, I've done this, I've looked at the child, he's got a normal neurological examination, his motor coordination is impacting his function from what I see. I've done my tennis ball testing and all that in my office, together with what I've collected. I have enough information to say, I think this is what it's going to be. I'm using that tool to be able to see what degree of motor coordination difficulties he has in 3 areas.
After that, we needed to do a
No. Not for the DCD part.
Okay.
Okay. No, at that point, I would go to the CAD Child website, go to the specific parts as related to the child of that age or that development age, where it's got the match strategies, have the parent and the school sit down what he's functionally having the difficulties with, gives you exactly what ideas, how to work on that, and how to break it down. I mean, it's all there deliberately to help out with that. Sorry?
It's a coordination between frontline physician, OT, PT, and school.
Yes. So yeah. And oftentimes I'll just say to the parent, take this in. It's got the home and school booklet, management booklet. Have them take it in, have a discussion with the LST at school.
Any speculation as to why there is an association between autism and developmental coordination disorder? Any speculation why there might be?
Go ahead.
What is it?
You have a thought? You have a thought?
No.
Oh, I thought you had a thought.
No.
There's something about the brain that didn't develop properly.
It's dysfunctional in a minimal
Yeah.
way.
Oh gosh, not that word.
But I think it's not just ASD, right? I mean, it's ADHD and all that. That's my question. So why then do we exclude intellectual disability? So people with Down syndrome are syndromes that are associated with low autonomy.
Well, we're not excluding them. We're just saying where their motor coordination difficulties at par where they are intellectually, or if it's below where they are intellectually, then that's a different
But even if
issue.
they're at par, because if we think, because with
Yes.
ADHD, and when we talk about comorbidity, is it really comorbidity, or is it just one problem that manifests itself? In
Well,
multiple
that's the
different
whole
ways?
issue about comorbidity.
But then with people with intellectual disability, with mild intellectual
Yeah.
disabilities, if their motor performance is similar to their cognitive abilities, why is that not seen as the same as somebody with ADHD with normal intelligence who has motor problems as well?
Mainly because after the expert consensus discussion, I will say it that way, because you know how the DSM works, I'm being upfront here, is that it was decided that it was only those where the motor issue was of a significant nature that was lower than wherever the intellectual level was, to a significant degree.
But it seems sort of an arbitrary thing.
Yes, of
Because you
course.
can say with ADHD that you can account for
Yeah.
that as well.
Yeah.
And it's just one of those things where so many things get excluded if they are
I know.
not.
And then let's talk about the clinical real world. Children with Down syndrome have low tone or behind in their motor, and it looks like they're having motor coordination. In other words, practice, 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 and they're still having trouble. Those kids benefit from the same strategies.
Did anybody watch that television segment? Our group from Florida found that the excessive movement in ADHD actually was useful to them in terms of concentration.
Saw that, yeah.
There was something recently, I
Yes.
didn't read the study, and that'd be the question, right? It's like,
Yeah.
the devil is in the details.
So what?
Devil is in the details.
Yeah, I haven't seen the study yet,
Yeah,
but that did come out.
Study, I heard that on the news the other day.
Yeah. But I haven't seen the study, so. But I did hear that their extra movements were actually helping them because there was something to do with, there was the feeling they had and there was visual they had that actually make them focus.
I wonder how they defined extra movement.
I don't know.
Get out of their desk and wander around.
Well, that's more than extra movement.
Yeah.
That's leaving the space to another space.
So why do you think developmental coordination disorder is in the DSM? Because it's a philosophical question I wondered about. It's same with speech and language.
Oh, same with speech and language. It's taking you guys on
But
too.
clearly they're not psychiatric disorders. In the sense,
Yes.
in childhood, we have things that are purely neurological, like tics, elicited in the DSM, and motor coordination or developmental coordination disorder and speech and language problems. In adult psychiatry, there's no similar equivalence, really. And it's just that I'm not clear why they're in the diagnostic manual of mental disorders.
Well, I'm not going to attack the speech and language. I'll let them do their own. Okay. From my perspective, the reason DCD, and this is what I do know, got into it was in DSM-4 as well, was because of the high association of the other comorbidities and making the point not to forget to look at the motor as contributing as part of it. That was the reason.
Jennifer, having done some of the training in the
I was waiting for you over there.
area,
I was trying not to stare at you.
I really want to put those plugins for bottom-up approach.
Yes.
So that a lot of the is a lot of top-down.
Yes, it is.
Cognitive strategies.
Yes.
Whereas I think you can develop hunter skills. I mean,
Mhm.
you can teach all these kids to learn these skills, but that generalization of being able to have the buttons and not being able to touch doesn't happen. Whereas if we strengthen sensory foundations involved in all of these skills, our body sensor senses, so our tactile sense, our proprioceptive sense, and our movement sense, usually those generalizations will come about faster. So I know we use both. I think the top-down and the bottom-up approach, but I think the sort of bottom-up approach of the sensory motor play for kids is really beneficial in the ability to generalize.
Right. And I mean, and again, I think it's that, which is best for that individual child. So I can jumping around. Which is best for that individual child.
Absolutely.
Some children definitely do better if they have the cognitive top-down approach, learning how to do the skill. Where's my body in space? What do I do first, next, and that? And then other kids do better working where am I in space, and going back up. So.
And I think our kids here at CRI that are so complex and do have all these comorbid diagnoses like ADHD, I think, and working memory problems, I think the top-down approach is often very challenging for those kids.
And that's one of the research debates that's ongoing is that issue. But for the DCD type things has been really good research to show that the top-down approach works for those kids, even with the ADHD, if you can get their ADHD under better control. That's the key part.
I was interested in the functional MRI piece.
Yes.
I went to a workshop on motor planning,
Yes.
and they said that a lot of the kids with motor planning deficits are motor planning in the moment, motor planning that one step.
Uh-huh.
They're not doing the 6 ahead like
No.
So I see those typical kids doing those 6 ahead things, those error, error
Yeah.
matching,
Well, that was that
learning at the
issue.
same
Yeah.
time where the motor planning problems are motor planning.
Right. And that's what the functional MRI showed. Typical TEDs were using the parts of the brain that had learning, relearning, had to correct in the moment for the error, and the DCD kids weren't doing that.
But that's why it's also really hard to separate that from ADHD generally.
Yes.
And so having a group who didn't have ADHD, it's the only way to do that.
Mhm.
But they're also not reflective of people with DCD generally. So
Right.
they're a unique, specialized group.
Correct. But the other way around, if you see here the motor coordination issue, right, is their primary reason they came to see you, right? You need to think about the other things.
Oh, absolutely.
But the other way around, you see the kids with the ADHD things, there may be other comorbidities, including DCD, that may be contributing to the problem. And we don't often look at the motor, is what I'm trying to say.
Child can't sequence motor tasks, so you look really.
Yeah, yeah. And it's that chicken and egg thing. It's hard to tease that out. But I think what we don't often do well, and it depends on, it's a little bit like the elephant model, you know? Everybody got together and the room was dark and everybody put their hand on the elephant, right? You're looking after that body part, that thing that's your specialty, but you're not thinking about all the underlying things. So just making the point that with the kids we see, if you see them for ADHD, you see them for depression, you see them for anxiety, you know, in addition to look at their learning and on the psychosocial, maybe we should be also thinking about the motor, which we don't always think. It's making that point. And around the other way, I have to do the other.
Yeah, unfortunately, I think politically, people are moving away from multidisciplinary and interdisciplinary.
Oh, don't get me into that whole thing again.
That's difficult. The kids
I know.
really do need a multitude of people. And it's more and more difficult to justify that.
And that's why I was saying about the resource things. So, I mean, it's easier to ask for a one-time consult than it is for ongoing. But DCD is really trying hard to make it so all the materials are free and you take them and you can adjust them to that individual child and issues. That was the point of it, because there aren't the people out there who do it. Yes. Yes.
Overall, it's an arbitrary decision. So I'm not sure why epilepsy would be So I think
But it's interesting, it's only in the childhood thing they include these sort of non-psychiatric things. Whereas in the adult part of DSM, there really is no similar. Well, that's good.
But my question was, what do we do with kids who have DCD, and it is a range? So these are often kids who are severe. And,
Yes.
you know, going to the website and trying is just, they're not getting better, whether it's cognitive problem or
Yeah.
social, environmental problem that they who we go to for help. Because
That's what you can
I
go
find,
to.
you know, a lot of those kids, the plan in school is not to.
Yes, in fact, they get opted out
That's not true.
rather than, yes.
So I think.
Mhm. Mhm. And that's what, yeah, that's what we were just saying, that you try them at this stage, at that, like I was just trying to put diagnosis, and then depending on the response to management, response to treatment, then you have to go to the next step and look what else for that individual child. That are easy access to me.
There, like I think pathways of life.
Mhm.
Lots of videos. They have some website. But I should say, I don't know, many referrals.
Maybe you weren't allowed to say that. I would say it for you.
But there are, we have a list of private practitioners
Well, this is shame,
But
it's
it's
where money
limited.
talks, is
There's
what
lots in Toronto area, like very populated areas of private pediatric OT. They lost under more than there's not enough direct services. There's not enough funded. There is a mistake. They seem to fund more direct treatment services. And then I think you end up with less severity of issues, but more like problems. And self-esteem and dropping out of school, I think in the long run, costs money.
Oh, yes.
Yeah. Perfect to do it here. Yeah, another 20 therapists.
So food for thought is the answer, and there's a lot of good research coming out of it. And so, but it gives a place where one can start or one to think about kids in a different way.
Sort of in anticipation of your session, I looked up the sports requiring the highest degree
Oh,
of
yes.
coordination and balance.
Yeah.
Any guesses? Which would be the sport?
Diving.
I would say darts.
Darts,
Gymnastics.
gymnastics.
Tennis. Racket sports.
Okay. The 10th most.
Here we go.
The 10th most difficult is gymnastics,
Mhm.
and then 9 is baseball, 8 is golf,
It's right there.
7 is diving. Somebody mentioned diving.
Yes, yes.
6 is shooting.
Yeah, you better be good at motor coordination with shooting.
You're running actually.
5th was fencing. 4th, surprisingly, lawn bowling. Sure. Who would think about that? 3rd is equestrian, horseback riding. And it's interesting how horseback
Yep.
riding is used for. 2nd is squash, and the most difficult for balancing and coordination, surfing.
Yep.
And
There's a count as a sport over there. Look at it.
So skateboarding too.
skateboarding,
Yeah, the same thing.
it's not listed.
Very good. Thank you. So, mhm. Yes. Okay, so what we usually recommend is, first of all, group sports is not top on your list. Okay? The second would be sports where they can actually work on a skill and move it along a little bit. So things like judo, karate, where you're able to talk yourself where your body needs to be in space, those kind of things. Swimming as well, where you can learn a skill and gradually increase the level of your skill, those. For sports activities, what we do suggest, though, is kids can be not in competitive sports, but in regular sports at school. They shouldn't be ostracized from the gym. But that outside of the gym, they either spend a little time with the gym teacher teaching part of a skill, so they can work on that skill as well, and teaching them the parts of the skills they need to do part of that sports, but not in a competitive way. And I was going to say the most successful kids that I've seen in terms of sports activities would be kids who do things like are the goalie of the hockey team. The very important role being the goalie. But the goalie, you can teach those skills needed to be the goalie in a graduated fashion, cognitive top down, as well as for those kids who have more problem with the sensory part. Easier than you could teach them skating and being a forward across the ice with all the stick handling. So, and goalie is a very important part of the team. Same in soccer.
So, so there's I don't know what George Bray's requirements are. Where they actually have to have an intellectual disability to participate in that league? Do you know George Bray?
Oh, I know of it, but I don't know what the
requirements
criteria
are.
is. No.
They have a hockey league, and it's for people with disability. I don't know how they actually define it.
Yeah.
But have a special,
It has to be through. There has to be something at school. And they go from 5 to 105. They get wide age range. And there is also, I mean, the Autism Society in London, they started a soccer league. I think they call it a league of their own, and I think their definition of autism is pretty broad.
It's very broad, yes.
Does everybody realize that Special Olympics were born here at CPRI. Dr. Frank Hayden was director of physical medicine at the university, and he used the Zarfus building and brought in, I'm not sure how many youngsters with Down syndrome, and developed standards for coordination at the Zarfus Hall, which was then published. Then it was brought to Washington by Eunice Kennedy, and the Special Olympics were born there. So started here.
My goodness.
Sarah's been harassing Dr.
Hayden.
Hayden. Sarah's been harassing Dr. Hayden to see if he would come and give us a talk. But so far, he has eluded her.
You tried?
Yes.
He doesn't have a big internet presence, so it's not easy to find.
Okay.
So I'm just gonna add, there is a website called Schulich, and you get that, and you put in your location, it will tell you any of the adapted. Once it, I have it on my wall as a poster, except for
Yes. Okay.
There's a quick little YouTube video. It's called "The Tragedy of First Position." It shows a little girl in a ballet class with significant motor challenges, multiple motor planning and balance challenges. And just how only a 1-minute video, but really powerful. How hard it is for this little girl to get her feet into that position, and she almost falls over, and then she spends the whole time trying to get her feet in that position while they're already moving on to like steps ahead of her.
Yeah.
Just in terms of the impact, on that activity not being the just right challenge for that little girl, her self-esteem.
Which is the first position? I saw it.
Something like that.
Is that like parallel to each other?
No, that's like something like that. That's the deal.
And on the Can Child website, they have videos of kids, and they're showing what you can do in your office setting. This is the tennis ball in terms of catching and throwing against all those kind of things. And it's just amazing to watch the child who wants to do it to that spot over there, and he goes like this, and it ends up over there. And then the next time, and he gets a little closer, but the next time it's way over there. He just cannot figure out what distance and what distance his arm goes, what strength and what gradation to go. And he trips over his feet and there's nothing there. And he starts talking to himself because he's trying to laugh about it being funny. And it's very sad.
What I always find interesting too is the kids who are very cognitively disabled, but are actually reasonably well coordinated. That it's one way I see it, probably in the 40s, I would think, and yet outside, if you throw a ball to him from 20 yards away, you can catch it.
Yes.
Which most people that I see with that kids like that can. It's you sort of wonder the opposite. What is it that he has that allows him to have that coordination? It's so much different from everybody else with a similar cognitive capacity.
Well, maybe those fMRIs going to show us those differences,
Yeah.
right?
That could be.
Yeah.
All right. Well, thank you very much, Jennifer, for starting us off. Can everybody please fill in the evaluation forms, and also just to sign in, please, so that we can.
I'll let you take it outside of somebody to give you
So next month, the second Wednesday month.
I didn't know it was the first of the year. You didn't tell me that part.
Red time, I think, or something like that.
So